All right, so straight to business. I'm not sure how many of us joining today were part of the previous sections, but I'm just going to give you a quick recap of what we've been doing in the last 3 weeks or so. So we've talked about the electrophysiology of the heart, and we talked about the conducting system of the heart. We talked about the peculiar characteristics of the cardiac muscles. We've talked about the cardiac activation process and the principles. We've talked about the definitions and the indications, the forms of ECGs. We've talked about the ECG directions. So when you see upward and downward deflections, you have a good understanding of what this represents. Okay. Components of ECG, we've discussed that, the P wave, the QRS complex, the T wave and the U wave, and what each of them represents. Okay. The QRS transmissions, how a normal QRS wave, QRS complex, how the transition should be, how the progression should be. We've talked about that. Last class, we talked about the intervals and the segments used in ECG. So we talked about the PR interval, the PR segment, the QT interval, and the ST segments in ECG and their clinical relevance as well. So we've talked about the ECG leads and electrodes. So I've told us how we use the 10 electrodes to generate 12 leads in a 12-lead standard ECG. Okay. So we've been able to identify the 12 leads and the 10 electrodes that we use for standard ECG. Then we spend a couple of time to demonstrate the Einthoven triangle. And this triangle is just an illustration of how the leads and how the augmented leads and the linked leads, how they combine to generate the leads you see on paper on the ECG. So how lead 1, lead 2, lead 3 are generated, how the AVR, AVL, and AVF, how they are generated. The Einthoven triangle is just an illustration of how these are generated. Okay, so if for one reason or the other you are not part of the previous lessons, then you can, I think I should be able to put it in the chat, put a link to that in the chat box. Wait me 1 second. Just in case you just join. All right, that's the link in the chat box. So you can help yourself and just look through the previous lessons. So for tonight, we're just going to be doing, it's going to be a quick one. Okay, so we'll be talking about the clinical scopes of the ECG leads. Then one of the most interesting part of ECG learning is the ECG calibration and standardization. And this is where it becomes interesting. Okay, this is where it becomes interesting. And I would like you to pay good attention at this point. Then I promised as well that we're going to be having a quiz at some point. I don't know how many of us are returning participants, like you've been participating or you've watched the previous lessons, but at some point today, we'll be having a quiz section and I'll be giving out a gift for whoever comes out as the winner. Okay, so that's just giving you a heads up ahead. So just a quick recap. My aim is to talk you through the clinical scopes of ECG leads tonight, but I need to reiterate the ECG leads themselves. just in case we have someone that's joining us for the first time. So ECG leads are categorized into 3 groups. So we have the precordial leads. These are the chest leads, and these are V1, V2, V3, V4, V5, and V6. Okay. So these are the chest leads. We have the augmented leads. The augmented leads are the AVR, AVL, and AVF. So there are 3 of them that are augmented leads. And lastly, we have the limb leads. So the limb leads are the lead 1, lead 2, and lead 3. And if you put these 3 groups together, this forms the 12 lead electrode, the standard 12 lead electrodes. So the 12 leads are made up of the 6 chest leads, 3 limb leads, and 3 augmented leads. When you have any ECG reports right in front of you, you'll be seeing the labeling on the paper. You see the V1, V2, V3, V4, V5, V6 labeled with different waveforms. You see different waveforms right in front of them. Okay, so this is how ECG paper, standard ECG paper is going to come out. In America, I understand it's labeled C1, C2, C3 to C6. It's still the same thing. It's just the nomenclature that's different. Okay, so these are the leads. So when we are now talking about the clinical scope, it's a factor of knowing where V1 is showing, where V2 is showing, where V3 is showing, where AVR is showing, and we can start making sense out of the whole stuff. Okay, so the clinical scopes of the ECG leads. So V1 to V4, these are the anterior leads. Okay, so they view the anterior surface of the heart, and I want you to put that down if you are making notes. Okay, so V1 to V4, these are the anterior leads. Okay, so what that means is they view the anterior surface of the heart, so they tell you whatever is going on in the anterior, in the sternocostal surface of the heart. Okay, so when you, for example, probably you see them interpreting ECG, and they tell you a patient is having anterior MI, and you're wondering how do they identify anterior MI, like anterior myocardial infarction, from maybe a posterior myocardial infarction, or from an inferior MI. So it's just the understanding of these clinical scopes. So V1 to V4 will tell you the anterior surface. Okay, so when you have lead 1, AVL, V5, and V6, so these are the lateral leads. Okay, there are 4 of them: lead 1, AVL, V5, and V6. If you are with me when I was talking about the electrodes, you will agree with me that the V5 and V6, they are more lateral. Okay, they are attached on the lateral surface of on the body, just the anterior axillary line and the mid axillary line. So they are more on the lateral surface when you are attaching V5 and V6 electrodes, and that is consistent with V5, V6 leads as well. So they show the lateral surface, not anterior, the lateral surface. Okay, beg your pardon. So we have lead 1, AVL, V5, and V6 telling us the lateral surface of the heart. So if there is an MI, for example, now in myocardial infarction, that is showing on the ECG, and those changes affect maybe leads V1 to V4, and also the lateral leads, then you can say, okay, it's anterolateral infarction. Okay, so it's just bringing 1 and 2 together. Then for the inferior surface, there are 3 of them. So these are lead 2, lead 3, and AVF. Okay, lead 2, 3, and AVF. So these are the inferior leads. So these are the leads that show the inferior surface of the heart. Okay, lead 2, lead 3, and AVF. Okay. There's a bit of controversy about V1 and V2, but it is generally believed that V1 and V2, they view the septum, okay, just the septum of the heart. Okay. Then AVR, it's popularly referred to as the cavitary lead. Okay. So AVR looks directly into the cavity of the right atrium. Okay. It looks directly into the cavity of the right atrium, and that is where the SA node is. Okay. If you remember the direction of ECG we discussed earlier, and the conducting system of the heart that we discussed, the SA node is meant to be the natural pacemaker, and that is located in the right atrium. Okay, so the AVR is the one showing us the activity in the right atrium, is the one that looks directly into the cavity of the right atrium, and by implication, this is why AVR in a normal ECG is always negative. Okay. AVR in normal ECG is always negative. Anytime there's a positive deflection in AVR, then it tells us that there is an impulse coming from somewhere other than the SA node. Okay, and that is ectopic. That's an ectopic rhythm. Okay, so that tells us that there's an impulse coming from somewhere other than the SA node. Okay, so when you look at an ECG paper, an ECG report, and immediately you fix your eyes on the AVR and you see any upward deflection, any positive deflection, then immediately you know this is not a sinus rhythm. There's an impulse coming from somewhere other than the SA node. So it is AVR that looks directly into that. For the posterior surface of the heart, you will need extra electrodes apart from the conventional 10 electrodes that we use, the 10 conventional electrodes that we use. So you'll be needing V7, V8, and V9, and those will be attached on the back, like the posterior surface of the body. So those will be attached on the back. So when we get to where we are talking about the correct positioning of the electrodes, then I'll tell you how you can position these electrodes. So the anterior surface, V1 to V4, lateral surface, lead 1, lead AVL 5 and 6. Those are the lateral surface, lateral leads showing the lateral surface of the heart. Then the inferior leads are the lead 2, 3, and AVF. V1 and V2, the septum, then AVR, the right atrium. I hope we understand that. So quickly, I'll move on to the calibration and the standardization now. And this, like I said, is one of the most interesting part of the ECG learning. Okay, and I'll be asking us a couple of questions at this point, so I want us to respond accordingly. Okay, that's the best way we can learn this without complicating it. Okay, so it's going to be more interactive. So the electrocardiogram is recorded on a standard paper traveling at a rate of 25 millimeter per second. That's the standard paper speed. Okay, that's the standard ECG paper speed. You just have to write that down. Okay, it's the globally acceptable standard speed for ECG. Is 25 millimeter per second. Okay, and like I said, once again, I will need your attention on this now. Okay, so the paper is divided into large squares, and each square is measuring 5 millimeter wide. Okay, if you've seen an ECG paper before, you will notice they are just a combination of boxes or square. You see the large squares with thick lines. Then right inside the thick lines, there are smaller. I think I should use another color for this. So right inside the thick line, there are smaller boxes as well. Okay, just pardon my drawing, but that's just something you're going to notice on the ECG paper. So they are made up of large boxes and small boxes. I'll be using the boxes and the squares interchangeably anyway, so it's still the same. So the paper is divided into large squares, and each large square measures 5 millimeter wide. And here I'll just ask you a very quick question. Let me get this off the screen. So if we say the standard ECG speed, the paper speed is 25 millimeter per second, and I've just said that a large square is 5 millimeter wide. So how many large square or how many large boxes will be traveled in a second? Okay, I need you to put that in the chat box for me. I'm going to wait for you now. Like I said, this is the only way we can work together and understand this. So the standard speed is 25 millimeter per second. That's 25 millimeter in a second. And I've just said the paper is divided into large boxes, large squares. Each large square is 5 millimeter wide. So my question is, how many large square are we going to travel in a second? So I'm waiting for your response. How many large square are we going to travel in a second? So we expect a normal cardiac cycle, a normal cardiac impulse to travel 25 millimeter in 1 second. Okay. So how many large boxes or how many large squares will be traveled in 1 second? If a large square is 5 millimeter wide. Okay, someone is saying 5. Anyone else? Quickly. Okay, so the correct answer is 5, which is absolutely brilliant. Thank you, nursing flood. Thank you. So you can include that as part of the standardization for ECG. So for a standard ECG speed, that will cover 5 large boxes in a second. Okay, that will cover 5 large boxes in a second. One more question on that. So if the standard ECG travels 25 millimeter in a second, okay, then how many seconds will it take to travel a large box? How many seconds will it take to travel 5 millimeter? If 5 millimeter is a large box, isn't it? So how many seconds is going to take to travel a large box? So if you are traveling 25 millimeter in a second and have said to us that a large box is 5 millimeter, okay? Someone already told us now that by implication, you are traveling 5 boxes in a second. Okay, so how many seconds will it take to travel a single large box, 5 millimeter wide? How many seconds? Okay, someone said 0.2 seconds. Okay, any other person? Anyone else? Okay, 0.2 seconds. So that's fantastic. Okay, and that is very correct. Okay, so applaudez-moi for nursing vlog. Applaudez-moi. So that's 0.2 seconds. So if it takes 1 second to travel 25 millimeter, okay, and 25 millimeter is 5 large boxes, okay, then it's going to take 0.2 seconds to travel 1 large box. So you just divide it by 5. Okay, so you just divide it by 5, and that's going to be 0.2 seconds. So thank you once again. Put that down as part of the calibration for ECG. Okay. This is the real in-depth, this is the real part of ECG interpretation. Once you don't understand this aspect, then I'm afraid it's going to be extremely difficult for you to understand ECG interpretation, because most of the things you'll be looking for, they will be in ranges. Okay, they will be in ranges, and they'll put the range down for you. So the only way you can understand if probably this is, for example, now if the PR interval is prolonged, how will you know it's prolonged? Okay, you just, because the only information you have would be the boxes. So you need to be adding them up. Okay, this is 3 large boxes, and 1 large box is 0.2 seconds. Okay, we just did the mathematics now. So 3 large boxes, 0.6 seconds. Then you can make your decisions from there. So that is how you understand the ECG interpretation. Okay. Another important part of the calibration that you need to know is each large box has 5 smaller boxes inside. Okay. So if you have an ECG paper with you, you see the thick line, which are the big boxes, the big squares. So inside the big squares, there are smaller squares. So a big box has 5 smaller boxes inside. Okay. The boxes, they are square, so equidistance. I hope we understand that. So they have 5 smaller boxes inside. So if I mentioned to us earlier that a large box is 5 millimeter, okay, then I just said to us again now that a large box has 5 smaller squares inside. So a small box or a small square is going to be how many millimeter? If I may ask us, how many millimeter would a small square be? If a large square is 5 millimeter and a large square has a further 5 smaller squares inside. So how many millimeter is going to be would a small square be? Okay. Anybody want to answer that for me? My apologies, I've pre-warned us that this is going to be more interactive, so I need us to respond. If you need me to repeat the question, then that's fine. Okay, someone said 5 mm. Okay, anyone else? A large box is 5 mm. That's what we just did in the previous slide. Okay, if I take us back, you can see this. I hope we can. So we can see this. A large square is 5 mm. Okay, and I said to us that a large square has 5 smaller squares inside. So a small square is going to be how many mm in width? Okay, it's going to be how many mm in width? Okay, someone said 2 mm. Okay, it's getting interesting now. Anyone else? Anyone else? Oh, someone said 1 mm. Okay, so we have 5, we have 2, we have 1. Okay. Okay, someone else is saying 1 mm. Anything else? Okay, well done, everybody. So the correct answer is 1 mm. Okay, the correct answer is 1 mm. So a large box is 5 mm in width. Okay, a large box is 5 mm in width. And if you further split that into 5, it's just dividing it into 5. Okay, so if you divide a large square into 5 smaller boxes, and I deliberately emphasized it that they are squares. So it's not like one is going to be 1.5, another one is going to be 0.5 or something like that. They are square, so they are equidistant. They have equal distance, equal sizes. Okay, so if you split a large box into 5 smaller boxes, and a large box is 5 millimeter, then one small box will be 1 mm each. Okay, so write that down and don't forget it. So 1 mm, one small box is 1 millimeter. Okay, please write that down and don't forget it. The implication is, for example, I told you when maybe you are trying to measure, do your measurements, And if you see, for example, what I've got on the screen now, you have maybe a particular wave that starts from the beginning of a large box and probably ends at this middle, somewhere here. So you can gauge the distance. Okay, so this is going to tell us, okay, this is a full large box. So this is 5 mm and just with two smaller boxes. So one small box is 1 mm. The second is, the other one is also 1 mm. So this is going to be a total of 7 mm in width. Okay, so you can apply that to your interpretation. Okay, I can only hope that you are understanding what I'm talking about. So there's still a couple of more questions I'm going to ask, but I hope you are noting it. So put it down. One small box is 1 millimeter. Okay. So the next question I'm going to ask now is, if the standard ECG speed is 25 millimeter in a second, which we've mentioned earlier, how many seconds will it take to travel a small box? Okay, I know that's it's a bit, but it shouldn't be as difficult. So if I will simplify it for us, a large box is 5 millimeter wide, and previously we've established that it takes 0.2 seconds to travel a large box. So if it takes 0.2 seconds to travel a large box, how many seconds is going to take to travel a small box? Keep in mind that a large box has 5 smaller boxes inside. So if it takes 0.2 seconds to travel one large box, which is 5 millimeter, how many seconds is going to take to travel a small box? I'm trying to be as simple as I can. Yeah, no. Okay, so one is saying 0.04 seconds. Okay. Anyone else? If you need me to repeat or paraphrase, just let me know. Okay. Five seconds. Okay. 0.04. Okay. Another person, 0.04. Okay. Anyone else? 0.04. Okay. So it's safe to assume that majority are going for 0.04 seconds, which is okay, which is very correct. So give yourself a round of applause. So that is it. A small box is going to take 0.04 seconds. Okay, 0.04 seconds. So if a large box is 5 millimeter wide, and that takes us 0.2 seconds. Okay, and I've mentioned that a large box has 5 smaller boxes. So one small box is 1 millimeter. So how many seconds is it going to take a small box? Just divide it by 5. Okay, and if you are old school like me, then you can do your mathematics and say, okay, a large box is 5 mm. What am I writing? 5 mm. Okay, and that takes 0.2 seconds. Okay, so a small box is 1 mm, and you want to know how many seconds it's going to take, so put that as x. So if you cross multiply this, so you're going to have 5x will be 0.1 times 1 is 0.2 times 1 is 0.2. So your x is going to be 0.2 by 5, and that will give you 0.04 seconds. Okay, so if you are old school, and so this is just a simple mathematics, okay, but you can just divide it by 5 because you already know this is 5 mm, this is 1 mm, so it's just 5 times the smaller boxes. Okay, so the correct answer is 0.04 seconds. So put that down in your notes as part of the ECG calibration. So if you followed me this far, then I can tell you that you are good to go. Okay, yeah, you are good to go. You've been able to, I can tell you now that you can successfully understand the interpretation of ECG. To be honest with you, not many textbooks will simplify it for you this way. They will just give you, just like a memory verse, they just tell you a large box is 5 millimeter. They will tell you it's 0.2 seconds. They tell you this and this. They won't tell you how they came across that, and makes it quite overwhelming. And this is my aim, to simplify this for us as simple as possible. Okay, and that is the aim of this lesson. Okay, we're still going to, I knew I said it that it's going to be for the month of May, but to be honest, I'm enjoying it. So I'll probably keep it up for the next couple of weeks. Okay, I was just minding my own business in my place of work last week, and a staff nurse approached me and said, "Wow, thank you for the ECG tutorial you're having." She's been part of it. She actually mentioned her lecturer. She said, Mr. So and so never taught me this way. He always made it look as if it's complicated and things like that, and she has never seen it that simple, and now she felt she knows better, and that gives me joy. I'm happy. The only concern I have is such people will refuse to give us a feedback, probably put in the comment section and let us know what impact this is having, or if it's actually benefiting you or not. Because I can imagine if our path hasn't crossed, I wouldn't know there's someone out there that is benefiting from it. Someone was actually telling me yesterday that I'm too proud. And I said, why would you say I'm proud? She said she has watched my teachings, and she felt I'm too proud to be begging people for subscription and comments, that I need to learn how to beg people for subscription and comments. Okay. So I'll probably learn that over time. But I strongly believe if you are getting value somewhere, then you don't need anybody pushing you. Anyway, if you are just joining us today and you haven't subscribed to our channel, please subscribe to our channel. If you are feeling blessed or you find this helpful, then let us know as well in the comment section. Share with your colleagues and your friends. Let them benefit. There's no pride in you monopolizing the knowledge. Okay, so share with as many people as possible. So let's carry on. So ECG standardization is still, so this is a pictorial representation of an ECG paper, just what we've been talking about since. And you can see the thick line represent the large squares, and inside the large squares you have the 1, 2, 3, 4, 5 further squares, both laterally and horizontally. You have 5 large squares, and you have the calibration here. You have this is the smaller boxes. You have 0.4 seconds and 1 mm. And what they don't put here for you is the calibration for the large box. But I believe you know that by now. The large box is going to be 0.2 seconds, and the mm is 5 mm. Okay, I believe we all know that by now. So summarily, a standard ECG paper speed, I put paper ECG speed, pardon me for that. So a standard ECG paper speed is 25 millimeter per second. ECG paper is divided into large and small boxes or small squares. Each large box contains 5 smaller boxes. Okay, a large box measures 5 millimeter each, and this is equivalent to 0.2 seconds. Okay, a small box measures 1 millimeter each and equivalent to 0.04 seconds. Okay, from our next class, we are moving gradually into the application part of ECG interpretation now. Okay. So we're going to be talking about how you can calculate heart rates from ECG reports. Okay. How you can calculate heart rate from ECG reports. Very simple. Okay, there are like 3-4 methods to get that done. So even without seeing the patient, just seeing an ECG report, you can calculate the patient's, you can know the patient's heart rate to the nearest decimal, okay, as accurate as possible. You can calculate that. So that's part of what we'll be discussing in our next section. Okay, so if you have not purchased a copy of my book, Synopsis of Electrocardiography for Nurses, okay, I will advise you to get a copy. I've put the link in the chat box. Okay, so everything I've been teaching us, they are just excerpts from the book. Okay, so it's best for you to have a personal copy of that, so you can get that on Amazon, and you can scan the QR code on your screen or use the link in the chat box. So it's quiz time. It's quiz time now. How many people are ready for this? So I will be giving out a copy of my book to whoever has the correct answer. So I'm going to be posting 5 questions, and to qualify for this gift, you need to get 5/5. You need to get 5/5. So I'll be posting the question in the chat box. Try your best to think about it. There are things we've discussed in our previous sections, I believe. I'm not sure I think they are mainly from our previous sections. So this is particularly to appreciate our returning participants. Okay. I'm hoping to keep this up for our next class as well. So if you miss out today, don't worry. Hopefully next class you'll be able to participate and probably have the opportunity to win. So bear with me 1 second while I post the questions in the chat, but there are 5 of them. All right, so let's, okay. Did I capture the last person? Okay. So the first question, says, Jane has just been diagnosed of a first-degree heart block. Which of the following changes will the nurse expect to see on the ECG? Okay, so I have some people go for the B. Okay, another person B. Another person went for where's number 1? Wrong PR, which is B. Number 1 B. Okay, so the correct answer here is a prolonged PR interval. So a prolonged PR interval is cardinal to heart blocks. Okay, either it's first degree or whichever degree. Well, a prolonged PR interval is what you expect to see on the ECG. So if you've got that correct, well done. Okay, so the next question. A patient requires ECG following a complaint of acute chest pain. While conducting the ECG, there were artifacts on the lead 1 and lead 3. Okay, so which of the limb electrodes will the practitioner aim to adjust? Okay, so I have here option A, which is the right arm. Another person, option B, left arm. Another person said left leg. Another person went for right leg. Okay, brilliant. So the correct answer would be the left arm, which is B. Okay, so the correct answer is left arm. So if you remember if you're with us when we are discussing the Einthoven's triangle, okay, so you have this, let me quickly bring that up in a bit. So you have this inverted triangle. You have your right arm here, you have your left arm here, and you have the left leg here. Okay, so we discussed then, so the potential difference between right arm and left arm is what generates the lead 1. Okay, so the potential difference between right arm and left leg is what generates lead 2. So, and that of left arm and left leg is what generates the lead 3. So this is how the 3 limb leads are generated. Okay, this is how the 3 limb leads are generated. So if you are conducting, remember these RA are the electrodes. The electrodes are the adhesive adhesive stuff that you put on the patients, adhesive stickers that you put on the patients. Okay, so these are RA, you put this on the right arm, on the left arm, and on the left leg. So if you have artifacts is like interference. So if you have interference that is peculiar to, for example, maybe lead 1 and lead 2, then you can understand that you need to adjust your right arm electrodes, because it is the right arm electrode that generates lead 1 and lead 2. Okay, so if there is interference with lead 1 and lead 3, if there are artifacts with lead 1 and lead 3, then you need to adjust your LA, the electrodes on your left arm, because this is the one that gives birth to lead 1 and lead 3. And obviously the electrode on the left leg produces the lead 3 and the lead 2. So if the abnormal ECG waveform, the artifact is peculiar to lead 2 and lead 3 alone, then you know that you need to adjust the electrode on your patient's left leg. Okay, so that is how to apply the understanding of the Einthoven's triangle. So if you were not with us when we were discussing this, then I would advise you to follow the link up and help yourself. So just go through the lessons all over again. Okay, so the right answer is going to be the left arm. The right answer to that is going to be the left arm. Let's stop sharing that. So the left arm is option B. So the third question, which of the following has the ability to initiate cardiac impulse? And I said, select all that apply. Select all that apply. So SA node, AV node, bundle of his left ventricles, and Purkinje fibers. So let me see what we have. Number 3. This person said A, another person said A, option 3, A and B. This option 3, this person said A. Okay, so for number 3, the answer is A, B, C, and E. Okay, A, B, C, and E. Okay, these are the things we've learned in the previous lessons, and I'm deliberately bringing this up so we can. Sometimes you don't know how much you've learned, and sometimes you don't know what you don't know. Okay, so this is part of what we've discussed in the previous lessons, and like I said, it will be helpful for you if you can go back and watch the previous lessons. So I mentioned to us automaticity as a peculiar characteristic for the cardiac muscles, okay, cardiac muscle tissues. What that means is every one of them has the ability to generate impulse on their own. Okay, so it's not just the SA node, it's not just the AV node, it's not just the bundle of every component of the conducting system of the heart can generate impulse on their own. Okay, so the SA node can generate, the AV node can generate, the East bundle can generate, the Purkinje fibers can generate, even though with reduced intrinsic rates, because the natural pacemaker is meant to be the SA node, but the AV node can as well generate impulse. The only thing is they can't do it as good as the SA node. Okay, so the best AV node can give you is maybe between 40 to 60 beats per minute. Okay, so and the intrinsic rate reduces with each of the components. So the bundle of these will be maybe 20 to 40, and less than will be the Purkinje fibers, but they still have the intrinsic ability to initiate impulse, though at a lesser rate. Okay. Number 4. Which of the following represents ventricular repolarization on ECG? I deliberately put this as a bonus question. So let me see if anyone has taken advantage of the bonus question. Number 4 is 4. Okay, this person said C. Number 4, yes, C. Number 4, QRS. Number 4, ESC, C. Okay, so that's absolutely correct. Number 4 is C. Okay. Ventricular repolarization is shown on the ECG as T wave. Okay, so the T wave represents the ventricular repolarization. It is not QRS. QRS is ventricular depolarization, ventricular contraction. That's QRS. So ventricular relaxation is ventricular repolarization. That is the T wave. Okay. The last question. Yeah. Dorothy has just had an ECG done, and a diagnosis of right atrial enlargement was made. The nurse understands that on ECG, the abnormalities of the atria will be shown on 1, the P wave, the PR segment, the QRS complex, the ST segment, and the T wave. So the question is, where will you see abnormalities of the atria? Is it on the P wave, PRS segment, QRS complex, ST segment, T wave? So we have A, P wave, A, P wave, A, P wave, A, P wave, A, P wave. Okay, so this seems like the actual bonus question because everyone got it right. So it's P wave. So it's P wave that tells you what's going on in the atria, either the right atrium or left atrium. You see that on the P wave. And if you want to have a good view of the P wave, you see that in your lead 2. Please note that, write it down and don't forget it. Okay, so lead 2 is mostly considered to be the rhythm strip. Okay, they consider it as a rhythm strip. So it is on lead 2 that you have a good view of averagely all the waves. Okay, but especially the P wave is mostly visible on lead 2. So if you want to make assessments, you want to see what is going on, then don't look anywhere else. You have to look at the lead 2. For example, you can't look at AVR to check for the P wave, because I just told us that AVR is expected to be entirely negative. So they are all facing down. So you're not going to make a good assessment of the P wave, not even a good assessment of the QRS if you are looking at it, if you are looking at the AVR. Okay. But when you look at the lead 2, which is the rhythm strip, then you are good to go. So those are the 5 questions. So what should we do? Nobody got 5. So do I have anyone that scored 4 at least? Do I have anyone that got maybe 4 questions right? Let me see. I'm not sure I have anyone that got 4 of the questions right. I think the best I have is 3/5. So what should we do? Let me see. So 1 is B. 2 is P. Seems like it's leading. 3. Nobody got 3 right. At least someone got A and B for 3. Yeah. B. 1, 3, 3. Sonia. Then 4. Yeah, for 4. C. So C. Then 5. Okay. Okay, I think nothing log scored 4. That's just the mathematics I just did now. Okay. So congratulations to you. I'm going to give you a copy of my book, nursing vlog. So if you can drop me an email, let me put my email address for you, then we can take it up from there. So that's my email address, nursing vlog. If you can drop me an email, then just screenshot this, screenshot this, then send to me as email. I have your channel as well, so I can confirm you are the one sending that to me. So well done, everybody, and congratulations to nursing vlog. So I hope you've learned 1 or 2 things tonight. Okay, so we'll be having this section. I think, I'm not sure when I'll be free again, but I'll communicate that, and I'll definitely let us know. So the quiz is probably going to form part of the sections going forward. So subsequently, we'll be having a quiz section, and we'll be rewarding people. Chini, I'm also proud of you for your efforts. Well done. Very good efforts. To be honest, everyone did brilliantly well. So well done to you. Okay, you deserve to be proud of yourself. Well done. Okay, so that will be it for tonight. If you are here and you have not subscribed to our channel, please subscribe so you can benefit in our subsequent sections. Okay, you can turn on the notification bell so that when we go live, you can be notified, because I'm not sure how many people I'll be able to reach sharing the link. But if you have the notification bell, then you will definitely be notified of any new updates or any section. If this section has helped you, please let us know in the comment section as well. Give us a thumb up. Just encourage, a little bit of encouragement, and that improves the visibility as well, so a lot of people can see it and benefit. Share with your friends, share with your colleagues, and let's build everybody up and develop as many people as we can. Okay, so thank you very much for staying with us tonight. I hope to see you again next section. I remain Nurse Adekola. So thank you. Have a wonderful night, everybody. I'll be expecting your mail, nursing vlog. Congratulations to you once again.